So I will share my presentation with you all. I hope it works. So first I have some BMT Classroom slides. Is that something that you want to say something about, or do I just hop on to how do you usually do? I never been to a session with you before. It's some information on the management team for the classroom.
So, Elin, you just go ahead with your presentation, and I
Okay,
think there'll be a
perfect.
chat session and a question session as you go along as well.
Oh,
Thank you.
perfect. Perfect. So, as said, I will talk about central venous access devices, and as a pediatric oncology nurse from Gothenburg, Sweden, our patients only have central line catheters because they are children. So that's something we handle every day. And I guess all of you, or most of you who are listening, have seen central venous catheters and learned about them in training. So my aim today is to give you an overview of some important information to consider when it comes to these central venous devices. And my aim is also to share the latest evidence regarding maintenance and management for patients undergoing stem cell transplantation. So some facts have been valid for a long time, actually, but it's always nice to confirm what still is the best option or what are the recommendations. So as said, I have my experience from pediatric transplantation, but the literature and research that I have reviewed concerns both adults and children. So it will be a mix, of course. And I will not talk about the insertion, what techniques are used, etc. I will only talk about the care that concerns our profession as nurses. So practical issues that are important for us to know or to discuss. So the agenda for me today is different central venous catheters, what types are relevant and what to choose. Complications related to central lines. I will talk a bit extra about central line associated bloodstream infections. Infection prevention, what kind of actions are important in care to reduce the risk of catheter-related infections. Maintenance, some specific just regarding PICC lines, management, and at least in the end, quality management. As a quality manager, that's something I never skip. So let's start with different central venous catheters. So the definition for all central venous access devices is that the distal tip of the lumen of the catheter ends in a large vein close to the heart. And this is really important because where the tip locates is important for the catheter's future function and possible future complications. And there are some general recommendations for when each central line should be chosen, but sometimes the reality is a bit different, of course. But I will here just mention some of the central lines that we have. So we have the non-tunnel one, which are mostly used in acute occasions and where short-term therapy is planned. We have the tunneled central venous access devices like the tunneled external central lines like Hickman for long-term therapy and more continuous use. And we have tunneled implanted ports, so port-a-cath, also for long-term therapy, but more if you don't need it more continuous. So on these pictures, I think there is some Swedish language, but at least you can see how the catheter is going through a large vein and going through the heart. And we also have the PICC line, which is a peripheral inserted central line. And that's also used for long-term therapy or for the middle time therapy, and it's inserted in a large vein through the arm, but it also goes all the way up to the heart. So that's also a central line. So which kind of tunnel catheter is used it's mostly for long-term therapy, and for our stem cell transplanted patients, that's the most commonly used central line in many countries. But which tunnel catheter is used depends on usually more this what the staff recommends. It is sometimes based on the therapy, or it also is a bit about tradition in the hospital. PICC lines are a central venous catheter that's also a good choice for stem cell transplant patients. I don't know how it looks in your hospitals, but studies show that PICC lines are safe and reliable choice for venous access in stem cell transplant patients. And it's also more and more common. It's not as common in the pediatric departments, but I know it's used in our hospital in Gothenburg, but also in other hospitals in Sweden on the oncology side and for stem cell transplant. We are not used to have PICC lines in our pediatric departments yet. We don't really have the knowledge and the experience, and the anesthetic team are not used to insert them. So which kind of central line is chosen for the patient is mostly about what kind of traditions you have, what kind of knowledge you have, what kind of competence, and who inserts them. So if it's PICC lines, in many cases it's nurses, but for pediatrics that's not always the case. So there are some examples of pros and cons to consider that does not depend on the tradition of the hospital, of course. When it comes to PICC lines, for example, it's safe and non-invasive, and it can also be performed if the patient has a low platelet count. When it comes to the non-tunneled central lines, it's used when you can't have the patient undergo a deeper anesthesia. So sometimes even if you need a tunnel one for long-term use, in the beginning you might have to choose a non-tunneled one because of the patient's condition. There are a few studies for PICC lines in patients undergoing stem cell transplantation, but the most studies are done on more oncology patients or ICU patients. Some studies are made on children with some similar results, but for children with PICC lines, it's also very important to be aware that the size of the catheter in relation to the veins are very important, because the larger the catheter, in small veins, there is an extensive risk of thrombosis. So regarding ports and external tunnel CVCs like Hickman, studies show that ports generally have fewer complications regarding mechanical and infections complications, especially in the pediatric populations. But these studies are not performed on stem cell transplanted patients. And how many lumens you need is also a bit on tradition, but it's in Sweden, even if we use different types of central venous access devices in different hospital, we usually have 3 lumens altogether for the allogenic patients. So preferably 1 tunneled implanted port and 1 tunneled external CVC, like a Hickman with 2 lumens. So usually use the Hickman, and when you need another device, you have a needle in the port and use that one as well. So we have some complications to consider, of course. The first ones are the insertion related. That's not really something that we as nurses can prevent, but we need to be aware of them. They occur within 48 hours after insertion. We have the pneumothorax, hemothorax, arterial rupture, and hematoma. Then we have some infectious complications. There are local or systemic, and I will talk more about the systemic blood infections. And for infectious complication, you say that it has to be 48 hours after insertion. We also have the mechanical complications like occlusion, rupture, displacement, accidental self-removal, and thrombosis. And it's a bit different how the complications are related to different catheters. Some studies show that the ports have a reduced risk of infections, catheter-related infections, compared to the other central lines, as well as they have less risk of mechanical problems like occlusion, breakage, or malfunction. Systematic review from 2023 comparing ports and tunnel CVCs in the pediatric oncology department showed that the CVCs, the external one, they increase the risk of systemic infection and mechanical complication, as well as a higher risk of needing to be replaced or removed. However, there was no risk of local infection and there was not any difference regarding thrombosis. So the risk of systemic infection is higher in hematological disease and neutropenic patients, of course, and the mechanical complications are more common in the external CVCs. But that may also be due to the fact that the ports, they are not used as frequently because that's the choice often. If you choose a port, implanted port, you don't use it as often as you do if you have an external CVC, and it's hang on the outside and it's therefore more exposed to accidents and risk of infection. And when it comes to thrombosis, it's either type of central venous access device. If you have it for a long time, there is the risk of thrombosis. It doesn't matter which type you have. And there is not a specific consensus on the pharmacological prophylactic treatment to prevent thrombosis. If you have a central line for a long time, the thrombosis usually comes. So the central line infections, there are many words for this, but CLABSI is a common way of talking about it. CLABSI stands for Central Line Associated Bloodstream Infection. We also have CRBSI, catheter-related bloodstream infection. Some only say CRI, catheter-related infections. But when you talk about CLABSI, it's more about the bloodstream infection. You want to focus on that. And there are different ways to diagnose this. And some say that these criteria is not it doesn't always apply the same for oncology and neutropenic patients. But there is a definition from the Centers of Disease Control and Prevention in the US that defines this as a laboratory confirmed bloodstream infection where a central line has been placed at least 48 hours before the event. So it has to be at least 48 hours passing after the insertion. And there are some signs and criteria for this, and there need to be a positive blood culture, and that's not related to another site infection. And you need to have fever, chills, or hypertension. It's a bit different if you're a child younger than 1 year. you can have more like hypothermia, apnea, or bradycardia as well. But positive blood culture, also not related to another site infection, is an important criteria, of course. And we have some risk factors for this, and all our patients are at risk. So hematology patients, if you have a PICC line or external central venous catheter, like I said before, that's also a risk. Hospitalization itself is a risk. And other risk factors are if you have multiple lumens, the more ways in you have, the more risk of infections. If you get blood transfusions often, that's also a risk. Stem cell transplantation and neutropenia. So even if you're not a hematology patient, if you have a stem cell transplantation for another reason, that's also a risk. If you are a very small child, that's also a risk. And if we as healthcare workers do not follow our standard guidelines and recommendations, that's also a risk. And just for the recommendations regarding these positive blood cultures, when you have a fever or a risk, you have a suspicion that's you have a central line bloodstream infection, you need to have blood cultures from each lumen of the central lines that the patient has, and also peripherally, if possible. And this should be done before the antibiotic treatment starts. And studies show that screening for central line infections if they are not having any symptoms, that's not recommended because it does not help detecting this early. So there are no recommendations for screening blood cultures to prevent infections from happening or to find them early and treat them. And if the catheter is removed due to possible infection, it's important to have the catheter tip for also a culture and to save it in a sterile tube. So you also see if you have bacteria or anything attached to the catheter itself. So when it comes to infection prevention for us nurses, there is a lot we can do, really. When caring for patients with central lines, it's important that the staff has the knowledge required and that the patient is so the patient is free from infections and have a well-functioning line. So the first thing is very simple. It's daily observation of the insertion site of the central line. If possible, without removing the dressing, if it's a transparent one, but daily observation is very important. When it comes to implanted ports, if the port does not have a needle and it's not used, then daily observation is not required if the incision site is healed, of course. Then it comes to the dressings. That's something that we discuss a lot in my hospital in our ward. So there is no real evidence indicating the absolute best dressing. The quality of the studies that are performed are a bit low and moderate, and it's difficult to compare studies and come to one conclusion. But altogether, the evidence can contribute to the indication that the use of a transparent dressing is what's recommended. And the frequency of the change should take place every 7th day. And earlier if it's soiled or loosened. And that seems to be the consensus that many decide, but it's not that the evidence is showing it, but it's the altogether conclusion. And if you have a gauze dressing that covers all, and you need to change it more frequently every 2nd day. because you need to see the insertion site, and it's not as practical for moist, and so you need to change it more often. And the risk to, at the same time, the risk to develop skin irritation is more frequent if you change the dressing frequently. So the longer the dressing replacement interval is, the less risk of skin irritation. So the change every day and a transparent dressing is the best option. There is also dressings with chlorhexidine gluconate. I don't know how that's said where you, if you are aware of that. They can be used, preferably a transparent one, so the skin is still visible. These dressings, they disinfect the exit site at the same time as it covers, but it also can cause skin irritation and contact dermatitis, and in rare cases it has caused anaphylaxia, but depending on the concentration of the chlorhexidine. But this dressing has been shown effective to reduce the risk of central line associated bloodstream infections. A literature review and meta-analysis from 2020 showed that the greatest effect in reducing these central line infections with these chlorhexidine dressings is seen in patients with a non-tunneled CVC, central line. So in the non-tunneled, it's the best effect. But it's also that you should not use these dressings right after they are inserted, because if you have a bleeding site, you should not use these chlorhexidine dressings. In children, the effect is not significantly showed regarding the reduced number of infections, and there have been more side effects regarding the skin, especially in the very small children, and there have been an increased risk of adverse events. So we have decided not to use these dressings in our pediatric department when it comes to our oncology patients. So because they also have seen in the adults that's damage to the skin with, if they have sensitive skin, that's contra introduction. So like if they have skin GVHD, these dressings are not preferred. And the exit site should be washed with chlorhexidine alcohol or similar, and exactly what to use for disinfection is not in consensus, but an aseptic technique is often recommended when you clean the exit site when you change the dressing. And if the port is used frequently, the needle should be replaced weekly, as when you change the dressing, so every 7th day. The weekly care for catheter and insertion site is different for if you have a well-healed tunnel catheter like Hickman type. If it's well-healed, you do not need to have a dressing, and if you don't have a dressing, you don't need to change it and have these routines like the others. But if you have a dressing on a healed Hickman catheter, you need to change it every 7th day. And there are some locks that you can have inside the catheters to prevent infections. There are some analyses performed that try to show that normal saline is as good or better than heparin. However, it has not been proven, but because of all of the studies have been done in different ways, and they report slightly different things. So it's difficult also here to have a definite conclusion, but no studies show that heparin is better. And sometimes heparin is also associated with other risks that as heparin can provide. So normal saline is recommended, just like heparin locks. And there are also locks with non-antibiotic and antibacterial substances like taurolidine. It has been shown effective in some populations, but the data is very limited, and it's also not always in high quality. And the results does not show the significantly lower rates of infections, but they can show a reduction of colonization of the catheter if you have an antibiotic lock like vancomycin. This is not something we have tried in my ward, so I have no specific experience from this. We have had taurolidine for a while, but we had 3 severe adverse events when using this for the first time. 3 patients had it, so we stopped, and now we only have normal saline for flushing and for locks. When it comes to hand hygiene, hand hygiene is the most important thing. Clean hands are always important. And scrub the hub is a common description of when you have a chlorhexidine tissue to scrub the end of the lumen before you use it. You can also have a disinfective caps like these on the picture. And there is no studies can't show the difference between disinfective caps or scrub the hub. Both ways are the same when it comes to effective, but scrub the hub is more cheap. If you have disinfective caps, you need to change them more often. So scrub the hub is what is still recommended in most cases. So we have a lot of maintenance to prevent complications other than infections. We have the fixation. So the reduce of reduce the risk of the lumens being damaged, jammed, or accidentally removed, the lumens should be fixed properly. That's maybe not a great risk in the adult departments as in pediatrics, but it's still a risk. You need to fix it somehow. And there are only general recommendations for this. We use tape, like the one you see on the single lumen, together with the dressing, but that's not really what's recommended as the most effective. An adhesive suture stabilization device is recommended, like the one on the picture here. That's an example from a PICC line device, but also the most effective one for central lines like tunnels, Hickmans. But the most important thing is to stabilize it and to have it not to be removed. When it comes to flushing, normal saline for flushing and flush clamping technique is what's recommended in most cases. And also when you flush, like you do it push by push, so you have, if you have something inside the lumen, some blood still there, it's easily removed if you flush a bit by bit. And when you stop flushing, you clamp the catheter at the same time as you are flushing to have a good pressure in the catheter. There is also recommendations of needle-free connectors, preferably with the neutral pressure. And we have one on the picture here. There are different kind of needle-free connectors, but it's very effective. You also need to scrub the hub for this, of course. When it comes to ports, so if the port is not used, if it's not in use, there are some recommendations to flush it every month for pediatric patients and every 3rd month for adults. But these recommendations vary also. There are no studies defining the exact science on this. If we have an occlusion in the catheter, either full or partial, if there has been a problem from start, the catheter might be too short, so you need to have an X-ray, and there's nothing we as nurses can do about that, but it's good to know that if it's early, since they got it, you need to have an X-ray. If it's partial occlusion, which means that if you can infuse but you can't get blood in return, the reason is most likely that the blockage is from hemolysis of blood. So installation of urokinase or alteplase like Actilyze in the catheter could help restore the patency. But there are instructions that needs to be followed carefully, and you can only do this with the doctor's order, and if the coagulation status of the patient is okay. So only when the occlusion is possible due to clots, you use this. If you have a fully blocked lumen, it can also be restored by a vacuum protocol, but that should only be performed by trained staffs and after doctor's order. So that's not very common in many nurses. When it comes to the attachments, like the infusion sets or caps, if you have a three-way line connected to the central line, there are some recommendations for how often it should be changed. And that's because some things promote microbial growth in the catheter. So when it comes to transfusion, the attachment device and administration set should be changed directly after any transfusion. The same is for parenteral nutrition, and that's because they have these factors promoting microbial growth inside the catheter that increases the risk for infections. And if you have if you use something intermittent, you need to change caps and tubes daily, as well as infusion sets. So there are some recommendations to our patients with mostly more sensitive for infections. And the most important thing is to know is when it comes to transfusion, blood, thrombocytes, plasma, parenteral nutritions, and when you use the central lines intermittent, you need to change the attachments daily. Removal of the central line, that's something that's discussed a lot, because you always need to evaluate the need. If you have a patient during transplant, you know the central line is mostly needed, but you still need to be aware that if the patient doesn't need it, it should be removed. Some types of infections, like fungal infections and staph aureus infections, you need to change, you need to take away the central line. And if you have some mechanical complications, of course. When it comes to PICC line, there are some specific things to consider, because a successful PICC line depends on a bundle of preventive measures, and it's similar to the other catheters. Many clinicians might still have old-fashioned ideas that PICC lines has a high incidence of infection and thrombosis, but latest evidence does not show that. And there are some results for PICC lines that show that there are almost no infections if preventive measures are taken. And this bundle includes careful site selection when you insert it, the skin disinfection before insertion, always the hand hygiene, and maximum barrier precautions when fixing it and cleaning it and changing dressings. The daily control on the indication if the patient still needs it, the daily control on complications, and the maintenance, the fixation and dressing and cleaning. And when it comes to, oh, no, I went to the other way, sorry. And when it comes to PICC lines, the total length of the catheter and the length outside the incision site is really important to note. So that's something that's different from the other catheters, because in that way you can always see if catheter has removed, if it's starting to come out more. So that's very important. When it comes to the management, the most important thing to make all of this previously mentioned work, it's training and education. Regular training for staff, clear standard operating procedures, checklists, bundles, access to the right material. So it should be easy for the nurses to do the right thing. All studies in the end are showing that training and education is the most effective way to prevent infections. Information to patients and maybe partner and families also very important. They need to know how the central line should be handled at home, information about dressings, bath, shower, and what they need to do if the central line breaks or leaks when they are at home, and if the exit site shows signs of infections. We also have documentation. That's very important. We know that continuity among staff is important, but the reality is a bit different. So we need to be accurate in our documentation. We need to document clearly and in detail. And in detail doesn't mean that we have to document a lot, but we need to be clear and straightforward so the next one can follow. How does the exit site look? How does the skin around it look? If there are any sutures left, how does the lumen function? When did the dressing change? And so on. So the next one can follow and do the right thing. And when it comes to this last topic, quality management, that's also something to consider. That's not always something on each nurse's mind, but we always should consider patient safety, and the department needs to perform audits or evaluate outcomes. It can be how many central lines did we need to replace this year due to infections or due to mechanical problems? Is there something we can change in our way to make them less changing of central lines? Is there something we can do to decrease the number of infections? So to ensure that we work in a good way, we need to measure and follow and analyze the outcomes, how common the catheter-related complications are in our ward, how many patients need to change, are the number within reasonable limits, or, as I said, can we change something? So reduce infections, they lead to reduced morbidity, reduced mortality, and less healthcare costs. So in the end, to have a quality management plan for central lines are very effective. So a short summary, I see the time has just run out. Daily inspection, hand hygiene, as for everything that we do as nurses, hand hygiene is very important. Change the dressing weekly, scrub the hub before using the central line always, educate the staff, educate the patient, use flush clamp technique. Normal saline is as good as heparin, and flush the catheter frequently. Use needle-free connectors. Use a good way to fixate and stabilize the catheter on the outside of the patient. And just as a remember, to choose a tunneled implanted port when it's possible. And a PICC line is a good alternative to other central lines, even during stem cell transplant. And don't forget training, information, documentation, and to audit outcomes and evaluate them. And these are my references if you want to read more. Thank you.
Hi, thank you, Ellen. We're going to open the floor to anyone who would like to ask any further questions. Thank you. That was quite summative and informative. And I think we are along the same guidelines that you are using out in Sweden. Our doctors also insert our devices. In the current population that I'm in, we're not using that many PICC lines, but we do use the tunneled and non-tunneled devices. Suffice to say, we've also started looking at the Toralox solution. And currently, with the adult patients, we haven't really had a reaction per se, but thanks for the input on that. We would look at it further as well. So if anyone has any questions, please go ahead.
I can just add something about the taurolidine.
Sure, please do.
And I had contact with a colleague in Belgium, which also had in the adult department some adverse events, but they not as many compared to how many patients they have, but they started to be more careful with the volume of the taurolidine. So they used only the exact volume of taurolidine that the catheter was had, so there could not be any more taurolidine into the patient. And that in that way, we did not really use it. We had like the same volume for all, like when we used heparin. So that's a way they used it instead, and it's working for them. Now I haven't heard anything else. So there are some good examples also.
Thank you. Good to know. If anyone else has any questions, please feel free to go ahead. I don't see any in the chat per se. So Ellen, if there's no other further questions, thank you, colleagues, for joining us for this informative session. I know Cyril's put out that the next session's in August. Please keep updated. And Ellen, thank you for your time and for your input and your papers as well. We really appreciate it. Thank you.
Thank you very much. Thank you all.
Thank you, everybody, for joining. We will be having our next session on August 20th. Thank you.